Okay, well, here we are. Welcome to Breaking Dimension.
I'd like to introduce myself. I'm a psychiatrist and a psychotherapist. I work in Switzerland, in a small town around in between Bern and Zurich, together with my wife, who is a psychotherapist sitting up there somewhere. When I was a young resident, I was introduced to psychedelics by my supervisor, and that was during the time where MDMA had not been banned yet, and we had this really incredible opportunity in Switzerland where a number of psychiatrists had licenses to use MDMA, mescaline, LSD, psilocybin, just without any regulations. So it was a great time of experimentation, and they developed how to do substance-assisted therapy in the group setting, basically. That's when I learned how to do this kind of work, and it kept me on the hook for all these years. I'm a member of the Swiss Psycholytic medical psycholytic therapy, and we've been trying to get research going for years, but we're practically all practitioners and do not have the background, the scientific background, and the resources to do this. So it was thanks to MAPS that we could jump on the train and do an MDMA PTSD study in Switzerland in 2006. So I'd like to talk about first why we should use, or we could use MDMA for PTSD, and talk about some of the risks and the possible benefits. I'd like to explain to you what MDMA-assisted therapy looks like, and then show some results from the Swiss and US studies, and I hope I have time to show you a case vignette. So why another new psychotherapy for PTSD? Do I have to explain what PTSD is?
Yes.
Okay. PTSD, post-traumatic stress disorder, is a serious, debilitating psychiatric condition which follows exposure to trauma such as combat or war experiences, torture, sexual assault, violence of any kind, natural disasters, and so on. And it involves symptoms of continuous re-experiencing in form of nightmares, intrusive thoughts and images, flashbacks, and so on, symptoms of avoidance. People, this re-experiencing is triggered by outside stimuli, and they tend to avoid these things. They go numb, emotionally numb. And the third cluster of symptoms is hyperarousal, which involves problems with concentration, with sleep, they are easily startled, and so on. It's a chronic condition. It has a high prevalence. In Switzerland, Switzerland is quite a safe country, and therefore the prevalence is quite low. But in the States, for example, you have a high prevalence, and in countries who are involved in armed conflicts, the rates are even higher. There's a high probability of chronicity, and the thing is, the main treatment for PTSD is psychotherapeutic, is psychotherapy, because the effect sizes are shown to be higher for psychotherapy than for the existing pharmacological treatments, which there are only two registered substances, sertraline and paroxetine, two SSRIs. They don't really work so well. The established psychotherapeutic methods are mainly exposure-based therapies such as cognitive behavioral therapy, and these kind of therapies usually have high drop-off rates of about 20%, mostly due to emotional avoidance. If you have to confront yourself with your traumatic experiences, not all people are willing or able to endure those difficult feelings and the fear. Another thing is that these therapies, these exposure-based therapies, were developed in university settings, usually one-dimensional, and it is not clear or uncertain how far these can be translated to everyday psychiatric private practice. So the patients I see in my private practice are way more complicated and usually not even ready for exposure therapy. So there is a need for more multimodal integrative treatments. And I think MDMA could be such one because it addresses much more than just the core symptoms or the trauma. So Neil also told you there's lots of anecdotal reports that MDMA works, that also other hallucinogens work for the treatment of PTSD or to resolve trauma. And during this time where we had special licenses in Switzerland, I saw it work many times with mostly people with childhood sexual abuse, rape, and things like that. And I saw it resolve not in a short-term manner, but over time under therapy with MDMA. Then MDMA has been shown safe in phase 1 clinical trials, and the first phase 2 clinical studies in Spain by Jose Carlo Bozo, and in the US, Michael and Annie Mithoff show really promising results. The risks, if we look at the risks first of PTSD, it's a chronic, debilitating condition. It has high rates of psychiatric and medical comorbidity, depression, anxiety disorders, suicidality. They are at risk of developing cardiovascular diseases, diabetes, and so on and so on. And they tend to get worse as they get older. There's a high risk of developing substance abuse, alcohol, and other substances. There are many disabled people who have PTSD. Rick told me yesterday that the VA in the US is spending billions of dollars every year just for disability. And people with PTSD cause high healthcare costs. What are the risks of MDMA-assisted psychotherapy? I deliberately wrote MDMA-assisted psychotherapy, not only MDMA. We must look at recreational use of MDMA and versus the medical use. There are over 450 cases of medical use that have been documented. It shows they can be safely administered with no adverse effects. And even in recreational use, severe MDMA toxicity is extremely rare. And the neurotoxicity question is handled very controversial, you know that all. There is a slight possibility of developing memory impairment. I don't want to go further into that. Psychological risks of MDMA-assisted therapy, you can develop anxiety, especially if you are suffering from such a disorder as PTSD, depressed mood in the days afterwards. There is a slight risk of abuse. Charlotte Walsh showed this graph where MDMA is, it was on the right side. The abuse risk, I think, is very low. And generally, the side effects are very modest. References to MDMA can be found on the MAPS homepage. It's quite comprehensive, this investigator's brochure will answer all your questions. Now, I'll come to the PTSD pathophysiology. You can find regularly a hypofunctional hippocampus due to genetic predisposition or a dysfunctional hippocampus. The hippocampus at this brain area is involved in memory building and plays a crucial role in PTSD. The second thing is a dysfunctional prefrontal cortex. The prefrontal cortex is responsible for the inhibition of the amygdala, which are the fear centers of the brain. And we have a disturbed HPA axis with lowered cortisol. The amygdala, the fear centers of the brain, are disinhibited or overactive. What we have found up to now is that MDMA neatly fits into this pattern of dysfunction in the brain where it deactivates the left amygdala and it stimulates the ventromedial prefrontal cortex. It sort of slips the brain into its normal function. There's a release of neurohormones, cortisol, which plays a role in memory building, oxytocin, which is being investigated for its prosocial effects, and also a prolactin. So on the psychological level, patients with PTSD, they cannot transfer their traumatic experience into a comprehensive and context of time, of space, and of previous and following and autobiographic information. This is called explicit memory building and takes place in the hippocampus. So if somebody is reminded of his trauma, if you ask him, how was it? This stimuli triggers an implicit memory trace in his amygdala and leads to a fear reaction, which is very distressing, so that in the future, this patient won't talk to you anymore about his trauma. These traumas have the quality of happening, these memories are experienced as if they were happening here and now, the same quality. Now, the psychotherapeutic principles in treating PTSD, the main goal is the building of a comprehensive, explicit memory of the traumatic events. There are 3 therapeutic ingredients, which means or correlate with activated neuronal patterns. The first, you have a repetitive re-experiencing of the trauma connected with an activated fear, negative feelings, avoidance pattern, and at the same time, you have a positive cognitive emotional state of mind incongruent with fear. That's how CBT works. And that's exactly, I think, what MDMA does. The result is that under the influence of MDMA, you repetitively experience that nothing harmful is happening at the moment. And this is not about insight, it's about experiencing that it is so. And this leads to the formation of new fear-inhibiting neuronal patterns in the prefrontal cortex. Let's come to the benefits of MDMA for psychotherapy. This is a bit complicated, but the basic thing is, or the basic message is that MDMA leads to a positive cognitive emotional state of mind with a fear reduction. It leads to a prolonged spontaneous reliving of and confrontation with traumatic memories. The recall of suppressed traumatic memories happens very often, and what Thorsten Passy calls a simulation of alternative behavior is sort of a role-playing in the mind, how things could have happened differently. And they sort of play different solutions, and this is rather typical of MDMA. Also, what is very valuable in MDMA, it's that it changes attachment behavior. You can regularly see that therapeutic alliance is much, much better after an MDMA session. In our trial, we had one woman who was a victim of ritual abuse, and she would not get into a bus with a man when there was another male passenger in there. So she had to sit with a male therapist, or lie with a male therapist and a female therapist for 8 hours in one room. It was gone. This symptom was completely gone after the first MDMA session. It's really a dramatic change. People who have problems with their bodies, such as eating disorders, who have eating disorders or have pain syndromes, they experience analgesia. They can reconnect with their body. The therapeutic approach and the role of therapists. The therapist should take a non-directive approach with letting the patient experience whatever is happening inside. They support this positive cognitive emotional state of mind. They should support intentions and therapeutic goals, pay attention to basic needs, and provide a safe and pleasant setting. They should provide a lot of reassurance when trauma comes up and help people endure the difficult feelings, the anxiety and the pain that comes up. So I'd like to explain our trial or our study that was completed in January now. This looks rather complicated. This screening part of the trial, we enrolled 12 subjects. They had screening measures. They were randomly assigned to four subjects were randomly assigned to a low-dose group, which consists of 3 MDMA sessions with 25 milligrams and a 12.5 milligram supplemental dose, and 8 received the full dose, which was 125 and 62.5. They went through 3 sessions with a day after integration session and 2 to 4, if needed, integrative non-drug sessions. The placebo group would proceed to stage 2 and could repeat the whole trial with the full dose. And after halfway through the trial, we noticed that we had several non-responders, and we got an amendment for another two MDMA sessions with a high dose of 150 plus 75 milligrams. The main outcome measure was the clinician-administered PTSD scale, which is a DSM-4 based interview assessing PTSD symptoms and severity, and the PDS, that's a self-report questionnaire. They were measured at 3 weeks after the second, 3 weeks after the third MDMA session, and 2 and 6 and 12 months as a follow-up. We had half of the subjects had sexual or physical abuse in childhood, 2 had rape, 3 were traumatized by medical treatments, and 3 were accident victims. So here are the results. They were not so stupendous as Tova's results. That's the baseline. The blue line is the placebo group. They went up a bit. They did not improve any. They felt a little bit worse afterwards, clinically and subjectively. And the red line is the decline of the full dose group. And CAP scores reduced by 14 points only, which did not reach significance. But surprisingly, after 12 months, they were down a lot more much. But this further decline cannot be attributed to MDMA alone. They went to another therapy. There might have been other factors that helped them get better over time.
Sorry, can you explain the green line?
Oh, sorry. The green line is the stage 2, where the placebo group went through the whole procedures with the full dose. They ended up a little bit better because they had double therapy, so to speak. This is the self-report questionnaire. This reached a statistical significant level. Same time points, 3 weeks post-MDMA-3, 12 months post-MDMA-3. This is Tova's results. They had a huge decline of 50 points. Where is it? Yeah, 50 points, and a highly significant result. We're still puzzled why they were so good and we didn't reach a significant level. We have no explanations yet. That's the placebo group of Tova. Basically the same results. I'll come to my case vignette. This woman was single, 20 years old, a carpenter when she had a motor vehicle accident, a head-on crash at the age of 18. And she had previously no history of trauma or psychiatric illness. She was referred to the hospital with a whiplash injury, developed a chronic pain syndrome in the neck and the shoulders, and has since then been disabled to a large part. She was 3 months in a clinic for her pain syndrome and had 24 months of psychotherapy for her PTSD. She became dependent on her mother, who just organized her life because of the debilitating pain syndrome. So in stage 1, in session 1, she developed all these feelings she had been avoided for years. The feeling of being trapped, feelings of being delivered, and of complete helplessness. She spontaneously associated them with the situation where the car crashed head-on. In the second session, she recalled having an out-of-body experience during the accident. She had completely suppressed that memory and avoided talking about it. She was completely confused about this memory in the days after. And in session 3, she was confronted with overwhelming negative feelings of guilt, of anxiety, what I don't remember what else. It was really tough on her, and this was with placebo. We were fooled. We thought she had received full dose. The only clue that it could have been a full dose was that she had a good appetite in the evening. That was all. But on the sessions, it looked completely the same as full dose. Here are some pictures she painted. This is fear, running in circles, being helpless for years. This is the accident where with the pain coming into her body. This is the incident where she left the body during the car crash here. This is her etheric body leaving the body. Her memory failed. She didn't remember anything of this, but witnesses of the accident said she was running around confused during in the minutes after the action. This is how she spent her last 10 years. The black part, mostly in bed with migraines, with pain, and only this yellow part was when she was feeling fine. This is a picture of how she avoided being remembered of her trauma, what she would also try to do to get out of the way of the trauma.
The word in the center?
Escape. Escape. In stage 2 with the full dose, in the first session, the numbing and the denial of accident just completely resolved in a few hours. She understood what happened to her during the out-of-body experience, and she reconstructed what had happened at the accident. In session 2, the confrontation was with the shock and the fear of death at the accident and her survivor guilt. The other car, there were 2 soldiers on weekend leave in there and they had died. And she felt guilt of having killed them for years. In the third session, she sort of came out of this out-of-body experience with, she went back into her body. I can't say it else. She retook possession of her body, and she began utilizing the out-of-body experience to control her pain in the weeks following the session. She had avoided looking at the newspaper reports of her accident for years, and she went immediately home and made this collage of mortuaries of the 2 soldiers who had died, of the accident, of her in hospital, where is it? Here with her boyfriend, and this after surgery.
Does that mean it happened?
Es ist passiert heißt it really happened. Yeah. Okay, I'll run through one more minute. And this is a picture of her really looking at her trauma, letting go, her thoughts. This was her constricted state before the therapy, and this was the more light state after therapy. Each one, this is a thought and a feeling which belong together each. Sadness, freedom, love and self-love, healing of the wound, revelation, gratefulness. And this is her CAP scores, and I examined her last week, and that was 24 months after the last session, and she no longer fulfilled the criteria for PTSD anymore. She could deal with her pain better. She was in a completely different state now, but it took her 2 years of hard work to do that. These are the quotes. You can read them yourself shortly. And she told me when I told her I was going to present her case, and she said, "Tell those guys out there, MDMA will open the door, but you still have to do the therapeutic work on your own. And people who will not willing to do this work won't benefit from MDMA." So it was her insight. So, I won't read it. Thank you for your attention.